from Adelaide, Australia, coming from the other side of the world. He says it's only a perspective, the long distance flight. Dr. Moore would say that the cervical pessary is an overt device for preterm birth, and I think that the next speaker is not here, but then we shall hear the other side of the point, please.
Yeah, thank you, Mr. Chairman, and thank the organization for the invitation, ladies and gentlemen. I was asked to make the plea for the use of pessary, and the tragical thing is that I addressed the same thing in the World meeting last year, and I only had to make one change in my slides. It was that my evaluation has changed, because I used to be here in Amsterdam. And my question to all of you, who has randomized into a study with a pessary and any other intervention in the last year? One, two. Sicko randomized the patient in the last year? I don't think
last year?
Last year? No. Very good. My conflict of interest of finance companies, and I'm neither a politician nor a diplomat. This is a slide I got from Otto Bleker when I decided to go to Australia. It's a 17th century map made actually by the Dutch, and they call Australia New Holland, which is the area where I live. Now I'm said to come from down under, but everything is a matter of perspective, because from my perspective, actually I'm the center of the world and you guys are somewhere here. This is the problem we are talking about, preterm birth, and a lot of statistics has been addressed, so I'll not do that. I'll go to the individual case, which is a Dutch poet, Gerrit Achterberg, who never had children but lost one child when he was 25. And he says, here lies the grave, that the smooth turf is the final piece of a brief awakening. 1 meter earth to equalize what for a short moment was on the rise. And that happens 1 million times a year. So the question is, what can we do about it? And I just heard from my opponent this morning that fetal medicine started in 1958. So one of the first innovations actually was the pessary around here since 1959. But unfortunately only addressed in good studies very recently. PSEP study, I think well known, by the Spanish group, singleton pregnancy with a short cervix actually found the benefits. They screened a lot of women, and in the end they randomized two groups of almost 200 women with a short cervix, to pessary or not. And I think to the surprise of everybody, they found a big difference where the group in red is the group without the pessary, and the group in blue is the group with the pessary. And most importantly, before 30 weeks, almost nobody delivers. So this has impact on the outcome of the babies, as can be shown here. If you look at the composite outcome, then that occurs in 16% of the group without the pessary, as compared to 3% in the group with the pessary, which is a huge benefit and statistically significant. The study has been repeated one time by the group in Hong Kong under guidance of T.Y. Lau, and they don't find a difference, but it's important to realize actually that the prevalence of preterm birth in that particular group, despite the short cervix, is very low. And if the natural course is already very good, and you can see that here in the control group, nobody is delivering, then it's almost impossible to improve. So how about multiple pregnancy? We actually heard from the result of the Spanish study while it was ongoing. You can debate whether we should have known that, but we knew it. So based on that information, we decided to evaluate pessary in a women with a multiple pregnancy, the so-called Pro-Twin trial, presented and coordinated by Suchi Lim and by Dick Baker, that you can see in the audience. Now, important to realize that if you collaborate, it's very easy to do studies. So my main message to everybody, don't believe that randomized clinical trials are difficult. They are very simple to do, and it's only us human beings who make them difficult. So if you could collaborate as a small country, the Netherlands, you can do these studies quite fast. We did such a study, and overall we did not find a benefit from pessary. So the poor perinatal outcome was 30% versus 40%, no statistically significant difference. As can be seen from the couple on Ireland. But then, surprisingly, if we looked at the group with the short cervix, and this is extensively described in the Lancet paper, we redefined that as a cervix under 38 millimeters, then we saw a difference in perinatal outcome, with a reduction from poor perinatal outcome from 29% without the pessary to 12% with the pessary. And it's very important to realize that death before discharge is the main driver of this. And that's because actually the effect of the pessary is mainly in the beginning, between 20 and 30 weeks. Because without the pessary, women start to deliver in that group, and with the pessary, actually, they stay pregnant until after 30 weeks. And if you deliver after 30 weeks in a developed country, you usually survive. So here you can see that again. Actually, there's a very limited effect on delivery before 37 weeks, but specifically delivery before 28 weeks has a spectacular reduction from 60% to 4%. And to put it graphically, this is the effect of the pessary in our study. This is the group short cervix without the pessary. This is gestational age. And what you can see is that the women who deliver before 30 weeks, so this group, there is very poor survival. Red is the children that die. And what then happens if the pessary puts in, basically those women deliver anymore in this area, they shift to over 30 weeks, and their survival is obviously much better. You can also show it in a post-hoc analysis where these are the primary outcome, neonatal complications, and specifically the blue group is with the pessary and the red is without the pessary, and what you see is that with the pessary actually there is specifically in the short cervix group a reduction to so-called normality, so to say. Now, are there new data? We have produced nothing in a year, which is, I think, a tragedy and maybe worse. What I know from personal information, and we might learn from Kypros, is that it's told that he has completed a short cervix study where, when put in at 24 weeks, actually the pessary is not reducing. I don't know exactly what the outcome is, but something 10%, 10%. And the other thing I have been told is that the Spanish PSEP group has also done a study in twins, will be presented this summer, and there is a reduction of preterm birth and no significant difference in neonatal outcome, but I was told that the point estimate actually was quite beneficial. Complications of the pessary. I think very little. This is the only case I got. It's cervical necrosis actually. So I think we should do better with randomized studies. I'm involved in GONET, the Global Obstetric Network, where centers around the world collaborate, and we have plans to do new studies. I'm aware of 6 initiatives actually of people who start studies in Brazil, in the UK, in the US. We start one in the Netherlands, and we're trying to start one up in Australia. And I would encourage everybody to join these groups and start doing them. Now I'm thinking already over time, so I want to stop there, or do I have more time?
How much do you need?
Oh, I can talk as long, but I think I got this statement here. Thank you.
Thank you. I think that we leave the questions after the next speaker speaks against Professor. No need to introduce Professor Nicolaides from London. I think no need to introduce. Nevertheless, he's well known all over the world and the prize winner of this year's award for the European Congress for Health and Medicine.
I'm not against the pessary, I'm very much in favor of the pessary. So we carried out a study to just confirm what I wanted to show. We took all twin pregnancies. The criteria were that they should be at 20 to 24 weeks, that there should be no major abnormality and no severe TTTS or selective IUGR. The mother should be more than 60 years old and able to provide consent, and that they should not be in labor or have a flash in situ. We gave them an information leaflet at the nuchal scan, and then again at the 22-week scan, which in England is illegal because you have to do it at a time when we cannot see, i.e. 12 to 18 weeks. But in my unit, we do it when we can see. We measure routinely the cervical length. And then we have an internet-based allocation, computer-generated random number list. We did a high vaginal swab, and if there was clear evidence, visual evidence of infection, we would treat them first and then put in the pessary. We followed them up every 4 weeks, and the pessary was meant to be removed at 37 weeks, or if they were having an elective iatrogenic delivery, or they went into premature labor. And then there was a logistic regression model taking cervical length into account in predicting the outcome. And then on the basis of this regression model for delivery before 34 weeks, we were told that we had to randomize 1,180 women to demonstrate significance at the 5% level with a power of 85% if the intervention would reduce the rate of preterm delivery by 30%. The primary outcome measure was therefore spontaneous preterm birth before 34 weeks, perinatal death, a composite measure of neonatal morbidity and neonatal need for neonatal therapy. There were several hospitals in England, Spain basically, and some other countries of people that in one way or another had been involved, were trained, participated in the Fetal Medicine Foundation training program. There were 2,000 eligible women, of which 1,180 agreed to be randomized, and then 590 in each group. They were very similar in all the standard characteristics that are associated with premature birth: method of conception, race, weight and height and age, and then smoking, previous cervical surgery, monochorionic versus dichorionic. The gestational randomization was 22 weeks, and the median cervical length was 32. And and the cervical length was less than 25 millimeters, in 18% in both groups. So very similar groups. I want to draw your attention about the measurement of cervical length by telling you my experience with the measurement of nuchal translucency, an obsession that consumed millions of pounds from the Fetal Medicine Foundation in establishing a process of training people for measuring a little black space with two white lines on either side. And it's difficult, and most people in the world don't measure it like that. And the few that do, when they send the results for audit, they fail, and then they have to be retrained to do it properly. There is no such process for the measurement of cervical length, but we have a process, and in our group, the cervical length is measured as Yuri Sonek originally described. Empty the bladder, vaginal scan, see the cervix, look at the endocervical canal, the white line, a black space around. This is the glandular epithelium, and that is the cervical length. This is the isthmus. If we do that, the median cervical length in singleton pregnancies at 12 weeks is 32 millimeters. In twin pregnancies at 12 weeks is 32 millimeters. In singleton pregnancies at 22 weeks is 32 millimeters. And in twin pregnancies at 22 weeks is 32 millimeters. This is the cervical length in this population. And the blues are expectant and the reds are the pessary. And the median cervical length was 32 millimeters for both groups. These are the results. There was follow-up in all but 3. 2 no follow-up in the pessary group and 1 in the expectant group. The rate of preterm delivery before 34 weeks was 16.5% and 15.5% similar in the two groups. And if we look at the spontaneous preterm delivery, it was about 13% in both. And this is the survival curve. And then, this is to make the results similar to the previous presentation. We looked at the cervical length of 25 millimeters. Again, there were no significant differences between the two groups. If anything, with the pessary, they were delivering earlier, but it was not significant, the difference. And then I look here at different gestational cutoffs, below 28 weeks, red, pessary, blue, nothing. 28 weeks, 30 weeks, 32, 34, and even 37 weeks. And then looking at cervical length at 22 weeks, and looking at the outcome of less than 34 weeks, and really, there were no significant differences between the two. And then the issue of removing the pessary. Now, we had this number of women where the pessary was removed before the primary endpoint, which was 34 weeks delivery. 31 women just wanted the pessary to be removed. A couple took it out themselves. Discomfort, vaginal discharge, bleeding, pain, real or imaginary, it doesn't matter. 31 women had the pessary removed before 34 weeks, and the vast majority carried on with the pregnancy. 22% delivered before 34 weeks. Iatrogenic, we use in England. In America, they call it medically indicated. Theoretically, it's the same thing. 18, and then they all delivered the next day or two because that was the intention. The women that went into labor, and this is a question mark that you cannot really control in a multi-center study. When somebody comes in and they are contracting and they are crying and they have pain and the contractions are getting more, in general, that is what we teach medical students, is called labor. So when the doctors think that the women are in labor, they just take the pessary out and they deliver. The one that didn't deliver was 33 weeks and 6 days, and she delivered the next day, so she was the day after. But actually, they all delivered within a day or so of presenting with premature labor. Controversy relates also to the PROM, because in the original protocol, we did not include PROM as an indication for removing the pessary, but I think that doctors, when they see ruptured membranes and they see a pessary, they just take it off, and the women deliver. Most of them deliver soon afterwards. So this is what happened in relation to the pessary. Now, neonatal outcome. Again, this is the distribution of gestational delivery of the two groups. Perinatal death, the same. Neonatal morbidity, the composite, intraventricular hemorrhage, respiratory distress syndrome, retinopathy of prematurity, or necrotizing enterocolitis, the same. A need for neonatal therapy, ventilation, phototherapy, infection, or blood transfusion, the same. So I'm very sad to say that in twin pregnancies, with any cervical length, insertion of a pessary at 21 to 23 weeks does not reduce the rate of preterm birth and does not reduce perinatal death or neonatal morbidity.
Here, Dr. Moore, please come to the podium. One point that I have to question is Dr. Moore's criteria were less than 38 millimeters, whereas Dr. Nicolaides' data show that the average cervical length was 32 millimeters at 22 weeks. So practically all twins should have a pessary. Isn't that true?
That's a question to me.
Yes.
I think there's one very important difference between the two studies, and I just want to congratulate my opponent, so to say, Kypros, on this study. Great work. But I think the biggest difference is that we did the cervical measurement at 16, 18 weeks, and the study that was just shown does it at 21, 23 weeks. So I think that's quite a difference. And the other thing I think is that we have very little insight in the standardization of cervical length measurement around the globe. So one thing we're doing now in the study I just mentioned, actually all the randomized studies on twin studies that evaluated progesterone, is to compare the normal distributions of cervical length. What I also can say is, compared to this study, our 17P study, the Amphia study that's done before, showed exactly the same distribution of cervical length.
Any comments from the audience? Questions? Yes, please.
Hi Ben. I mean, the two things that need explanation. Professor Nicolaides got a bit of a track record of doing this sort of stuff. Why has he got it wrong? Because I can't quite understand that.
I don't think it's about right or wrong. I think together with the groups I mentioned, we are the only ones who produce data. So I think the people who are really wrong are the ones who are not producing data. And otherwise, I think the biggest difference is just the moment of gestational age that we do the randomization. And also what I showed you, the fact that the pessary in our study basically delayed the moment of delivery until after 30 weeks. And after that, there was no difference in it. And this also explains the big rate specifically in mortality. So I think actually that the potential benefit of the pessary is to prevent delivery at 23, 24, 25, 26 weeks. So if you start your intervention at 23 weeks, you might be a bit late. And it's very good that we know that. I think all studies that will evaluate pessary now should, I think, consider to do that a bit earlier.
And the other thing that needs explanation is the very high placebo rate in the original trial, 25%, and everyone else gets it under 10%. Does that have a good explanation?
You mean in our study?
No, in the original pessary trial.
Yeah, but we found in that, you mean the singleton study? We found in our pessary study also an extremely high morbidity rate in the lowest 25% of the cervical population.
I think that one big difference really relates to the measurement of cervical length. In the Fetal Medicine Foundation coordinated centers, there's an obsession. That's why I mentioned the issue, the measurement of nucleus efficiency. My assumption, because I have psychological problems, everything that I read I do not believe. I have this problem in life. I believe that doctors are not born with the genetic knowledge of how to measure anything. Actually, the ones that think that they do are inevitably wrong. So, for everything, they need to learn how to measure things, and they need to be audited to confirm that they know what they are measuring. That is the starting point. The cervical length is 32 millimeters at 12, 16, 18, 20, 22, 24, 26 weeks in singletons and twins, and it's as simple as that. Now, in Holland, I think that, and you mentioned that process was not happening. The group of people that do ultrasound scans in Holland is very, very heterogeneous. There is a relationship between the cervical length and the size of the woman. The bigger the woman, the bigger the legs, the bigger the head, the bigger the cervix. But I do not believe that the average cervical length in Holland, even if the women are bigger, is really 47 millimeters. So I think that they were measuring something beyond or other than the cervix. If that is a starting point, then any conclusions relating to cervical length must be questioned. I think that in your data you have shown that the rate of premature delivery was identical in the two groups, isn't it? And the distribution of delivery was identical. The only thing that you have found is that in a very small subgroup of women that had a very short cervix, for a narrow gestational age, which contributed correctly to the significantly improved perinatal outcome, there was a difference. It is possible that that is true, but I suspect that that is not. It's just.
Well, my reaction is that, if I may, is the following. I mean, your argument would go perfectly all right if you would favor cervical measurement and I would not. But if I would have a lot of random error in the study, then I could not show these associations. So random error actually decreases the strength of the association. Now, I acknowledge that it might be that the definition of cervical length is different, and that we, for example, have exceeded every measurement with a centimeter or so. But then still, the distribution story stands.
There's a problem now. So there's a problem, and that relates to the Nick Wald philosophy of nuchal translucency. Nick Wald said, you don't really need to be trained to measure nuchal translucency. We will fix it for you retrospectively. Measure it however you feel like it, and you will make an individual sonographer retrospectively normality. But the problem with that is that if you do not know how to measure something, then if you are not properly trained to measure something, you are not consistently overestimating or underestimating, you are making a mistake all the time. No.
Well, I mean, random error doesn't produce the associations I showed, and I told you we consistently also have found this association in other studies. My big question to you and to everybody is, what do we do from here? We have shown, that a potential very cheap intervention has an effect, not only on preterm birth rate, but also on neonatal outcome, that is far more significant than any other we have produced, including progesterone. So why don't we do massively studies? We have randomized nothing in a year.
I feel very guilty that
You're the only one
for some divided loyalties or some strange way of thinking, I haven't published these results, although we completed the study last year, and we also found that there was no effect in singleton pregnancies. It will be published now. Jacques is running after me every other day. So the truth then, from the scientific point of view, is that we have two major singleton pregnancy studies, one that shows a massive benefit and one that will show that there is no benefit. We have two twin studies that both show that there is no real benefit in reducing the preterm delivery rate, but in a small subgroup of women with a badly measured cervical length that happens to be, honestly, you cannot speak to any person that has done ultrasound scans since the days of Ian Donald and claim that the 25th centile of cervical length in twins is 38 millimeters. I mean, I cannot imagine that anybody in the world will not laugh at that statement. Because if you're going to follow that instruction, then everybody has a cervical length of less than 38, probably measured in the world. Honestly, it's impossible. So, the conclusion, however, from the scientific point of view, is that when you have contradictory studies, then you waste a bit of more time and energy repeating and creating another study. So you are right in that respect. You will be busy a bit more.
No. I did my work. I'm not gonna accept it. And that's happening actually a lot. That if a study should happen in the world, that people point at me, but you guys should do it. Everybody, really. Take the initiative or join people who do it.
And it's not
the only way to make progress.
It's not as easy as you said. We wanted to do a randomized study on aspirin in England. We had to employ a CTU which has cost us £500,000. We had to go through various committees which take us 6 months and various regulatory bodies. It is exceptionally difficult in so-called civilized societies to do randomized studies. Like exceptionally expensive, exceptionally difficult. And then, if you're going to do them with operate on dependent measures, nuclear translucency, cervical length, uterine active facility index, then it's a massive undertaking to regulate the training and the auditing of those measurements. Otherwise, the results are there.
I have some objections with this. I noticed I was only given 10 minutes.
Okay, but
15 minutes. But my final 5 minutes would actually be that the problem that we don't want to evaluate is that we don't want to know truth. We want to create our own truth so that we can live comfortable for ourselves in our comfort zone.
okay, let
Because
us
trials
be
are not difficult at all. And the fact that they are made difficult is because we want that to happen. Because then we don't have to face truth. Now, I'm not sure whether the pessary really reduces preterm birth, but I think it's really unacceptable that something that has been put in our field in 1959 is not evaluated in 2040. I mean, this is between unacceptable and maybe it's even criminal.
Okay, let's one more question. I saw in your criteria that parity was not included. Did you control for parity? Because parity is has a major effect on twin gestation length.
Parity in terms of previous premature birth.
No,
The rate of previous
this is a risk factor. I mean, the parity the woman delivered in the past has been shown repeatedly that women that are previparous or secondiparous, multiparous, have a different gestational age than that. Consistently in tenth of papers.
The incidence of previous preterm birth in the two groups was the same, but the number of previous babies, I didn't.
Look at that because it might explain a lot. Parity is a major factor of success, but we cannot take it. Okay, it's a given. Okay, thank you, doctors, for the. Now, between Nicolas and Ruben Quintero, I have to give my lecture.